Hello and welcome to the Gustavo Franco podcast, where we explore the multifaceted world of healthcare. I'm your host, Gustavo Franco, a passionate healthcare student and researcher. Our mission is to better understand the U.S. healthcare system while studying both its flaws and strengths, as well as comparing it to other healthcare systems around the globe. Not only do we examine the policies and regulations behind healthcare, but we also take a closer look at the experiences of patients and doctors within the system. We aim to provide listeners with a deeper understanding of how healthcare truly operates. We share stories of individuals navigating the U.S. healthcare system, as well as present engaging interviews with professionals offering their experiences and expertise to help us understand the inner workings of healthcare. We believe that an informed public is the key to creating a more effective healthcare system, and we dedicate ourselves to this mission, providing insight and analysis on the ever-changing landscape of the U.S. healthcare system. Join us as we embark on a journey of studying healthcare together. Please note that the opinions expressed on this podcast are ours and of our guests, and do not constitute any professional advice. While we strive to be as accurate as possible, we acknowledge that there are often many viewpoints on a given topic, and our research may not be exhaustive. Therefore, we encourage listeners to engage with the subject matter and conduct their own research and confirm any information before making any decisions. Thank you for listening and joining us on this healthcare exploration. Welcome to the Gustavo Franco podcast. I'm your host, Gustavo Franco, and today we have a very special episode for you guys. We'll be talking about racial discrimination and systemic racism in healthcare. Joining us is a figure whose work has been nothing short of revolutionary in the world of healthcare equity, Dr. Christopher King. Recognized as a top minority business leader by the Washington Business Journal, Dr. King is now the Dean of the School of Health at Georgetown University. Here, he oversees the human science, global health, and health management and policy programs. Prior to his work at Georgetown University, he was at MedStar Health, where he was the assistant vice president to community health and led many community-based initiatives to bring about health equity. Before that, at the Greater Baton Medical Services, Dr. King raised over $7 million in grants to bring about health equity. I would be remiss not to mention Dr. King's extensive list of publications on systemic racism and racial discrimination in healthcare. He also did his PhD in Health Systems Administration from the University of Maryland. I'm very excited to have Dr. King on the episode today, and I hope that you guys will learn as much as I will. In this episode, we'll cover the definitions of systemic racism, racial discrimination, and health inequities. We'll talk about the current landscape of these issues in the society right now, in the US right now. Where do we see health disparities in our country? Why are health outcomes by race so different? We'll talk about specific cases such as maternal mortality or cancer survival rates. We'll also talk about COVID and how COVID saw many disparities based on race. We'll then go into the history of racism in healthcare. We'll talk about key events that have led to the system that we now see with racism integrated in it. After that, we'll talk about how we can address all these differences. How can we address the systemic racism that our society now faces? How do we address the 400 years of history where people of color have been discriminated? We then talk about philanthropy efforts, how our narcissist society can improve on themselves to better foster a home for all of these initiatives that will help bring about health equity. We then finish off talking about technological advancements and artificial intelligence and how that can be used as both a pro and a con, a positive and a negative, to addressing healthcare inequalities. So stay tuned, and I hope you enjoyed today's episode. Hey, Dr. King, welcome to the podcast. Very excited to have you here.
Thank you for having me.
Yeah, of course. I just want to give the listener a bit of a background. We've been working together on the 2024 Community Health Needs Assessment for MedStar Hospital, and I have to say, many of the topics that we're going to discuss here today, I've been able to actually experience and see them firsthand through working on the project. So I'm very excited to pick your brain and actually learn why this is happening and where it actually all arose from,
I am so excited that you are working on that project. I mean, it really gives our students an opportunity to see real life, like what's happening in people's lives that's preventing them from living optimal health and achieving, optimal well-being. And so I'm eager to hear when this is all said and done, the impact that it's made on you and how you think about what's needed to improve health.
Yeah, definitely. I mean, we'll go more into the community health needs assessment later on when we talk about the strategies to tackle systemic racism. But for now, I just want to make sure we clarify a couple terms that we're going to be using throughout the episode. We're going to talk about racial discrimination, health inequities, systemic racism. So I think it would be good to just define those terms for everyone out there. I know even I have difficulty sometimes just distinguishing between each of those. So could you just describe for us what we mean when we say that there's racial discrimination in healthcare or systemic racism in healthcare?
So let me first begin by just teasing out the difference between disparities and equity, right? So a disparity is a measurable difference. So when we're comparing comparable populations and we see differences in health outcomes, that's a disparity. It's empirical. You can measure it. You can quantify it. What causes these disparities is these are inequities. And simply put, that means one population has access to opportunity, more access to opportunity than another population. Very simple, right? How do we fix that is very complex. So when we think about systemic conditions, these are what's built into the fabric of our institutions and the systems that govern how we live. When we see that a particular group of people are suppressed or oppressed because of, in this case, we're talking about race, you're going to see differences in the outcomes of those populations that are impacted. So when we talk about systemic racism in health, we're talking about how race is, and again, it's not race that's causing differences in health outcomes. It's the environment and the conditions.
And I think that's
right?
something very important for us to get across, because I remember I was introducing this topic to my father when I was home for Thanksgiving, and he said that it was wrong of me to talk about these topics and say that there were racial differences in healthcare, because he thought that we were referring to biological differences in races. And that's not what we mean. I just think that we should get that across right away here because, we are not talking about biological conditions. We're talking about, race is a social construct, right? The Human Genome Project reaffirmed this for us in the 90s, right? It is a social construct. But for so long, because of our history, it has been a key driver for how algorithms are developed or how patients are treated. We think that just because a person is of a certain race, that they are predisposed or they're more likely to have a particular condition. And that may be the case, but we also have to think about why is that? And it's typically because of environmental conditions. COVID was a great example of that, right? Yeah, and I'm sure we'll talk about that later on. Just going back to the idea of disparities and inequities, would you say that by the way that you described it, first we have systemic racism, which leads to inequities, which leads to discrimination? Would you say that that's how it goes? That's a good way of thinking about it, or
I would say
is there a better way?
Yeah, systemic racism leads to differences in access to opportunity. And when I say opportunity, I'm talking about access to education, high quality education, access to affordable housing, access to healthy food and walkable communities. That's what I mean by opportunity. And we know that those things are key contributors to our health. When we don't have access to that, our health is impacted. So systemic racism leads to differences in people's lived experiences, which ultimately contributes to these devastating outcomes that we are so frequently talking about in our work. So that's how I think about it.
Sure. So you wrote a paper, The Healthcare Institution, Population Health, and Black Lives. And I think you actually have an interesting holistic way of viewing racial disparities in healthcare. And you talk about how, as you just mentioned, the differences in health outcomes is not solely due to medical or the healthcare side of things, but because of all the other social determinants that are at play that we see inequities in. But there has also been a lot of research taking into account for all of these other social determinants of health, and we still see significant differences in health outcomes between races. Is that right?
That's correct. That's correct.
Okay.
Because we really have not moved the needle in these environmental conditions, right? Our students learn about redlining, right? This is a practice that has gone on for way too long, where communities were literally divided and people of color were forced into, for example, the south side of Main Street. And the north side of Main Street was where we'd have more affluent white populations.
And I think people often forget how recent all of this really was. I mean, we're going to go through the history later on, but it's just, it's shocking.
We're still seeing the effects of that, and we're still in it. And so as a result of that, we will continue to see these disparities, because of the communities or the environment in which people are living. There's a difference. And you can look at our city. I think you've seen some of the data between Ward 7 and Ward 8 and Ward 3, right? In the District of Columbia, just a few miles apart, life expectancy is like a 16-year difference. And infant mortality rates are like 6 times higher in or east of the river, right? We can't blame the healthcare system for that. It's bigger than that. And so for so long, the healthcare system has been like, it's your responsibility. And I'm speaking for my colleagues in healthcare. We've done a lot, right? We've really, really done a lot. And we continue to do work in this space, but we can't, the healthcare sector cannot be fully responsible for addressing these conditions.
Yeah, no, definitely. And I think that's super important that you mentioned that, because on that paper, you also talk about how the healthcare system can tackle these discrepancies in healthcare.
Yes.
And you say that, sure, we have internal strategies as to how the healthcare system itself can tackle this, but we also have external strategies that we involve the community. And that's the most important, right?
And that's been my contribution to healthcare, right? It's like, okay, we know it's bigger than us. We also know that we have work to do. And I know we'll talk about disparities in health care, because that's another area we need to tease out. There's disparities in health more broadly, and there's disparities in health care. Disparities in health care refer to differences that patients experience when they are within the walls of an institution because of their race. Disparities in health are just more broad, right? Like I was telling you about Ward 7 and 8 versus Ward 3, health outcomes are different. And so healthcare institutions, if they truly are committed to advancing a population health agenda, meaning that they want to improve the health of all of the people that they are serving in a community, they have to think about how they can use their agency, their resources to improve the infrastructure of the surrounding communities.
Definitely.
In addition to the work that they need to do within the walls of the healthcare system to make sure that all people have an equitable experience.
Yeah, and that's great, because I think it really puts into perspective how healthcare systems can actually address all of these differences. And it doesn't put all of the burden on the healthcare system itself.
Right. The other piece, if I can add, is the healthcare system has to have strategic partnerships. We have to have strategic partnerships with community-based organizations, because we can't do it all, right? So food insecurity is a perfect example. Well, healthcare systems aren't in the business of delivering food, right, to patients when they need medically tailored meals. But there are community-based organizations that have that mission. Mm-hmm. And so how do we have strategic partnerships with these community-based organizations? And how do we make sure that these community-based organizations have the revenue that they need to pursue their missions? And how do we make sure that as a society, we recognize that these community-based organizations should be perceived as part of the healthcare continuum?
Yeah, no, definitely. And I think that gets a lot into the strategy as to how we tackle all of these inequalities, right? Before we go there, I just want to make sure we understand the term social determinants of health. And I struggle with this sometimes. Would we say that race is a social determinant of health? Racism is a social determinant of health? Or racial disparity? Like, what is a social determinant of health?
Yeah, I would say racism definitely does impact health. When we think of social determinants, we're thinking mainly of like food and access to high quality education, access to clean air and drinking water, all those things. But we know that because of racism, people of color are more likely to be on the bottom of the totem pole, historically speaking, right? And that leads to these differences in outcomes. So yes, you can perceive that as we call, during COVID, we call racism a public health issue, right? Because it is, because when you look at the populations that are underserved, they're likely to be communities of color, and we're likely to see differences in their health outcomes. They fare worse.
Yeah. And then in terms of just race itself, I know that earlier you said race is a social construct. Yeah. Would it therefore be correct to say that race in itself is a social determinant?
I would not say that that's an inaccurate statement.
Okay.
Absolutely. But I'm cautious in saying that because I don't want to conflate the social determinants with race, right? It's like,
definitely,
right? It's the race that unfortunately is causing us to see differences in social determinants or who has access.
Yeah. So it's not the race itself that's a social determinant, but the social construct that was built around race.
Yes. Racism, I would say.
Racism.
Yeah.
Perfect.
That sounds better.
Yeah. So I was reading a paper by Kamara Jones that I know you also quote a couple times in some of your publications.
One of my heroes. My sheroes, excuse me.
Yeah. So she defines racism and breaks it down into 3 different categories, which I thought were super interesting. And I actually want to read the definitions of each of those here because I just thought they were amazing. And I think everyone should be able to distinguish between these 3 types of racism. And I think it really encompasses all types of racism that we see. So I'm going to go through each of these and we can chat after I go through each of them. So she breaks it down into 3 levels: institutionalized racism, personally-mediated racism, and internalized racism.
Yeah.
First, institutionalized racism. She defines it as differential access to the goods, services, and opportunities of society by race. Institutionalized racism is normative, sometimes legalized, and often manifests as inherited disadvantage. It is structural, having been codified in our institutions of custom, practice, and law. So there need not be an identifiable perpetrator. I think that's very powerful right there. And it's very powerful. It gets to the idea that racism is ingrained in our policies. And even though we might not see it firsthand, it's in there, you know?
Can I give you an example?
Please.
This was an aha moment for me when I was working for a health system. I presented to the board, and the board was a majority white board. Right. This was about 10 years ago. And I remember after that board meeting, I had to meet with one of the ER doctors who worked in one of those hospitals as a part of that system. So I did my presentation, predominantly white board, drove to one of their hospitals. Soon as I get into the ER, I see a whole lot of Black and brown people. And I remember thinking, wow, we have this board, these folks who are making decisions about how care should be rendered to a population that they are so disconnected from. Shame on us.
Right.
That is an example of how racism is built into the institution of healthcare.
And we don't even realize it.
And we don't realize it. And you don't blame one person, right? It is systemic and it is normative, right? That's the way the system has been designed. And so they're missing the mark and they're talking about, oh, we have to address health disparities, and the people from the community aren't even at the table. Those voices aren't being heard.
Yeah.
That's a problem. And then we wonder why we don't see improvements. Mm-hmm. We wonder why we still have distrust in the institution of medicine or the institution of healthcare in communities of color, right? It makes total sense. Mm-hmm. It makes total sense. And so what the healthcare system needs to do, it needs to have what we call a come to Jesus moment, right? Where you look at who you are, how you've done your work. I call them critical audits. Critically audit your work through a racial equity lens. And this is tough work because it may cause you to totally rethink your business model.
Yeah.
And that's really hard for folks to do, especially when you've been doing it for so long, when you have been the one who's been privileged as a result of the history.
Definitely.
You know,
So now let's talk about a form of racism that is not so obscure that we can actually see, and that is personally mediated racism. She defines that as prejudice and discrimination, where prejudice means differential assumptions about the abilities, motives, and intentions of others according to their race. And discrimination means differential actions towards others according to their race.
Yeah. Can I give you an example?
Please.
Pain management, right? Pain management, right? If you look back into history, and I'm going to name drop, Medical Apartheid is a great book for anyone who's interested in learning about how Black and brown bodies were used to advance medicine in the most unjust and inhumane ways.
We'll talk about slavery later.
Absolutely.
Because, I mean, it's shocking.
Absolutely. It really is. So it's important to, I just lost my train of thought. We're talking about, this is the moment.
Personally-mediated racism.
So with pain management, right? So we see this in Black males, especially when they have pain, that there's this mindset. It's implicit bias. I don't think she used that language, but it's a bias, right? That providers may have just because of the history or just because of this unjust world that we live in or how Black men have been portrayed, right? That they're seeking drugs. Right? We see this a lot. That is an example of the second example that Dr. Jones is mentioning. So it's a differential, it's a difference in treatment based on a person's identity. We see people who don't speak English as a primary language tell us that they get the sense that folks think they aren't intelligent just because they don't speak English as a primary language. So these are biases. These are differences in how people are treated. These are inequities that we see in healthcare. So that's number two. And I can go on and on with plenty more. But
I just think one example that he brought up there, the idea of medical students and medical staff not really understanding these differences and thinking that African Americans have a lower sense of pain perception or thicker skin.
Yeah.
There was a study that looked at 400 medical students. I think it was 400 medical students.
Yeah.
And a lot of them had these biases, even though they're in what we call the finest medical institutions in the world, right? They had these biases and thought that different races were biologically different, as we talked about earlier.
That study was done in 2016, and they were looking at biological fallacies, right? And when it came to, do people of color have thicker skin? Are people of color better, when it comes to pain tolerance and pain, are there differences there? And they found that folks still have these perceptions, and it's like 2016 at the time.
Yeah.
Where does that come from? It begs the question. Where does that come from? Do you think they were explicitly told in their curriculum that these are true characteristics of Black and brown bodies?
Even if they weren't, I don't think they were told the opposite, though.
I don't think they were told that. I think it is so, again, systemic and embedded in medicine that it just shows up in ways that we can't call it, right? And so what we've challenged many of our med students to do is to, again, critically audit case studies. And when they see these things where they see these types of injustices and fallacies showing up, say something. Because again, we are swimming in this. Sometimes, look, I try and be as aware as I can of what's happening in the world, but sometimes I lose sight because it's just the way that we live our lives, right? And so I don't fault those students, and I don't call them bad. I don't say they're racist. I'm saying they are a product of a world that has taught them implicitly and explicitly that there are differences in people based on skin color. And that's work that we're talking about 400 years of, well, more than 400 years of a world, of a country that has been built on these premises and these mindsets.
Definitely. Now let's talk about internalized racism, because this was one that I wasn't really aware of before. And it's really interesting if you start paying attention to it. She defines internalized racism as acceptance by members of the stigmatized races of negative messages about their own abilities and intrinsic worth.
Yeah.
I think that's super interesting.
That's super interesting. It's very deep and it's very real. An example I can give you is you have, you think that if you have two businesses, one is a Black-owned business and one is a white-owned business, and you're a person of color, that you're going to get better service from the business that is white-owned. That is an example of that. Right. And we see that happening. So this is internalized. And again, why does this happen? It's because of the world that we live in. But we've been brought up thinking that White is the reference group. White is the gold standard. And that's unfortunate. And it definitely needs to be called out when it happens, and it needs to be addressed.
Yeah. And correct me if I'm wrong, but minorities usually report lower levels of perceived health.
Yes.
Like for their own sake.
Yeah.
So I don't know if that could at all be related to internalized racism, or would that just be in comparison to all the social determinants at play?
I think it's the latter. I think it's a result of just the experiences that people have. For example, we know that you can take income, education, you can level that playing field, right? And you control for those variables, and you will still see differences in patient experiences because of race.
Yeah.
Right. There's significant evidence. Serena Williams, I know we'll talk about that.
That's exactly what we're going to talk about now.
Right? Yeah. Serena Williams, Beyonce. I mean, so it's not about income. It's not about education. It's you peel back the layers and what's left, it's race.
Yeah.
Right.
Let's actually transition into some of the evidence for all of this that we've been talking about. Let's talk about maternal mortality and then cancer, because I know you did your dissertation on that. Yeah. Maternal mortality, big problem in the US. We do worse than all other developed nations. If you break down maternal mortality between white women and black women are 3 times more likely to die from birth. Now let's control for a college education. Mm-hmm. Let's say you take a black woman who's a college graduate and a white woman who's a college graduate. It's even more extreme here. The black women are 5.2 times more likely to die from birth. And then you compare the college graduate black woman to a white woman who hasn't even completed high school. The black woman is still 1.6 times more likely to die from birth.
Yeah. What's that all about?
Right, exactly.
Right? What's that all about? I will argue it's not a biological issue. It is a lived experience issue. We know that stress kills. We know that racism impacts our minds, our bodies, our hormones. And we also know that women of color have a different type of experience with their medical providers. We've heard many women say they don't feel like they're being listened to.
And I think that takes us perfectly into the Serena Williams example.
Serena Williams.
Dr. Shalone Irving,
yes.
who worked for the CDC, dual doctorate, died. She died from this, and she was doing all her work on the same issue, and she reported everything that she was feeling to her doctors, and she just wasn't listened to.
So that's, again, racism in medicine, right? And we can trace all this back to, I always reference, James Merriam Sims, the so-called father.
Yeah, we'll talk about that for sure.
Gynecology, and how enslaved women, black women, their bodies were used to advance what we know about women's health, particularly around vaginal fistulas, right? And so he was a very influential player in gynecological education. And I would argue that his teachings help us understand, even today, 2023, why this phenomenon still exists.
Yeah, definitely. Now let's talk a little bit about cancer, because I know you did your dissertation on that. There are a lot of disparities. I know you specifically talk about minorities and how minorities will actually become technically a majority by 2050, right? Because the minorities are supposed to represent over 50% of our population by 2050. So I think this is very relevant in our world today. So I would love if you could talk a bit about.
So I'm glad that you're bringing up the word minorities, because there's a push to eradicate that word from our lexicon. Why is that? Because we know the people of color are a global majority, right? And we also know that just the term, the word minorities itself connotes, less than. And so what I'm just, in my work, and I have to, again, critically audit my work. And I go back and read some of my publications that I wrote like 10, 15 years ago. And I'm like, oh my God, I can't believe I kept saying minorities. But that was appropriate for the time, right? But now, after George Floyd's murder, right, we have just evolved as a society. It's unfortunate that it took that, but we're much more critical of things, and as we should be. So back to your question, when it comes to cancer, we looked at cancer survivorship. So we looked at anyone who'd ever been diagnosed with cancer at any point in their lives. And we wanted to see what are some of the barriers that are preventing them from sustaining routine care. Because after a person has been diagnosed with cancer, they still need to have routine services to just ensure that they're okay and the cancer doesn't come back. And so we looked at cancer survivors. I think it was about 13,000 across the nation. And we wanted to see what the barriers were. We looked at cost as a barrier. We looked at organizational factors as a barrier. And we looked at transportation. Organizational barriers are things like hours of operation don't fit my schedule. Right. Because I can't get off work Monday through Friday after work and I get paid by the hour. Or I need weekend services and you all don't offer weekend services. Or I don't speak English. I need a translator, but those services aren't available. So I just don't engage in care. So anyway, we looked at 13,000 and this was a disparities study. So we're looking for quantifiable differences across different racial and ethnic groups. And what we found was that cost is number one. Organizational barriers was number two, and transportation barriers were number three. And we also saw that patients of color were more likely to experience these barriers. So that, again, helps us understand why, like, let's take breast cancer, for example. Did you know white women are more likely to develop breast cancer?
No,
yeah.
I did not know that.
White women are more likely to develop it. Black women are more likely to die from it. What's that all about, right? Series of things. It could be late detection. It could be one of the issues I just mentioned, cost as a barrier, organizational conditions as a barrier, or transportation as barriers, right? And there could also just be cultural barriers, right? Let's just pray. Let's pray and it'll all go away, or let's pray for it and let's not put too much emphasis in the healthcare system. So there's multifactorial explanations for why we see unfortunate outcomes when it comes to cancer. But we do know that, again, race, when we peel back the layers, what's left is race and differences in people's experiences.
Yeah. Just going back to the idea of minorities, should I say people of color? How would you?
I like that. That's what I say, because I was giving a talk and one of the people in the audience said, well, I hear what you're saying, Dr. King, but what am I supposed to say now? Right. And I said, well, you just say people of color. And I think it also depends on the context.
Sure.
And your audience. That's another thing to consider.
All right, cool. Yeah, I didn't know that.
Yeah.
Thank you.
Yeah.
Thank you.
Yeah.
Now I want to go into the historical context. Sure. We've talked about some events, but I actually made a list of a couple of events that I think have really shaped racism in healthcare right now. Please, these are not exhaustive of all events that have happened. So we should keep that in mind. But I think these really shaped where we're at right now. So as we go through them, we'll talk about them one by one. First, I have medical experimentation in slave populations. Mm-hmm. You talked about James Marion Sims, seen as the father of gynecology. He was experimenting in Black slave women without any forms of anesthesia. Why? Because they said that they had a lower sense of pain perception.
Yeah.
Yeah.
And we don't know their names, right? That wasn't told. By the way, there's a statue erected of James Marion Sims in Central Park. I think it was the early 1900s. It was recently removed because of, a lot of advocacy for it to be removed. But most people don't know the names Anarcha, Betsy, and Lucy, right? Anarcha, Betsy, and Lucy were the three women that are documented in the literature. And there's so many others, but they were heavily documented in the literature to be the ones that he did these awful experimental procedures on. Where's their statue, right? Where's their statue? And what do we do with his statue? That always comes up.
Was there any pushback in removing his statue?
Oh, of course, yes. Yes, there was pushback. Just like with other statues that we're seeing across the country. It doesn't have to do with healthcare. It could be Confederate Like, there's pushback, right? Don't erase our history. This is our history. The question is, what do we do with that statue, right? I would argue, I don't think we need to destroy it. I think we need to tell the story of who this person was, right? Tell the truth. Enlighten the American citizen. Inform the American citizen. Do not misinform or miseducate the American citizen. And that's what's been done, right? Tell the true story of Dr. Sims, James Marion Sims, and the women that were victim of this abuse. We need to just tell the story.
Yeah.
So, and let me give you another example of a hospital CEO wanted to do the right thing. This is why we need diversity around us, because if we don't, we can step in some stuff, right? So he said he learned about Anarcha, Betsy, and Lucy through a lot of the DEI work we were doing. And he wanted to do something for Black History Month. And he said, let's have an event to celebrate Anarcha, Betsy, and Lucy's contribution to medicine. That was him really wanting to do the right thing.
Right.
But it was his colleagues of color who said, no, that's not how you say that, right? You don't say, we're going to celebrate their contributions to medicine. These women were tormented. So I understand what you're trying to do. Maybe we need to tell the story of Anarcha, Betsy, and Lucy, but I don't think it makes sense. And so they were able to pull him to the side before the flyers were released, that they were celebrating Anarcha, Betsy, and Lucy. Instead, they recontextualized the event around telling the truth around our history. So,
and that gets to the point of good intentions, but
very good intention. Yes. And a lot of people have a really good heart and want to do the right thing. But sometimes you just need to run some things by the people that are most likely to be impacted and make sure you get it clear. Because you can lose, you know, if you're not a part of that community, you can lose sight of the sensitivities associated with it. Like, I'm not a woman. Like, if I'm doing something I want other women to give me input into what I'm doing to make sure I don't get it wrong.
Yeah. I know another topic you're interested in is segregation in healthcare during the Jim Crow era.
Yeah.
I don't remember much about the Jim Crow era from high school. So I would love if you could just talk a little bit about
right?
that.
So separate but equal, but they weren't equal, right? They were separate. And again, I'd like to use the south side of Main Street. You know, they had separate facilities, but when it came to the quality of those facilities, they were vastly different from the folks who lived on the north end of Main Street, right?
So that's how it plays a role in health.
Oh, absolutely. Yeah. And so you're going to see differences, not only in health, but you're going to see differences in the access to education. You're going to see differences in access to high quality healthcare. You're going to see differences in just the resources that are in communities that we know are important for health and well-being. So that had a devastating effect. And David Williams out of Harvard, I have the most respect for, has done a lot of work on this topic. And in his research, it's been very clear that communities thrive when they are integrated. We have all kinds of people in a community. It's better for everyone. It's better for health outcomes. It's better for their own lived experience. People are enlightened by diversity. They think and their horizons are broadened by diversity. So makes sense.
Yeah.
Now
let's talk about immigrant medical examinations. There was Ellis Island, Angel Island. Immigrants were coming in. Immigrants of color were being examined in very different ways than white immigrants were being examined. Could you talk about a little bit of that?
I'll tell you what concerns me about that. And, at the School of Health, we have a global focus, is we're all human. And when we start giving a specific community access to vaccinations or resources that we know, and especially if it's an infectious disease like COVID, for example, everyone's going to be impacted. So it's important for us to prioritize the most vulnerable. I say this all the time. If we can fix the system, if we can meet the needs for the most vulnerable, everyone will benefit, right?
Yeah.
And so this goes back to, your question is like, I think about the values that we have as a country, and it's always me, my rights, versus community. All right, I've been looking at Thailand and how they think about these things, and everything is about what's good for the people, for everybody, not just what's good for me. I really think that's part of our problem, is that we have a society, I'm speaking of the United States, that values individual rights. Don't get me wrong, I think that's important, but that's prioritized over what's best for everyone. Right. And that's what we do at Georgetown. It's the common good, what's best for the common good. And that's what we teach our students.
It's all about the community.
It's all about the community and recognizing that we're all in this together. We are a global society.
Yeah.
We're global. So we need global health public policy, right? We need that. We just can't be so segmented and this country gets this or this population gets this population does. Because when it all falls, when all of the dust settles, we're all in this together. So what's best for the common good? And I think if we rethink and we prioritize that, we'll all be so much better.
Yeah. Now I want to talk a little bit about the eugenics movement.
Yeah.
I don't think people realize how recent some of it was, right? But it happened late 19th century, early 20th century, even going into the late 20th century, honestly. And for people who don't know what the eugenics movement was, it was basically, we're saying that only certain people are worthy of reproducing, right?
Yeah. Well, the eugenics movement was just around Black folks were inferior. They're genetically different. They're more likely to be violent. That was the eugenics movement. And so, yeah, it wasn't long ago. Right? I always talk about Carl Brigham, who was the founder of the SAT, who was a key proponent of the eugenics movement. Now, this is a person who thinks that Black people can't learn like white folks. Founder of the SAT. And then we talk about the SAT doesn't have bias or standardized tests aren't racially. Well, they are. They are.
Yeah.
And so, yes, and the eugenics movement also helps explain the study that you referenced in 2016 that focused on biological fallacies, right? It helps understand that. See, Gustavo, this doesn't we can't eradicate 400 years of damage overnight. That's why it's important for us to be very intentional, to be very critical of our work, to make sure that we're surrounded by different people with different perspectives to catch us when we're about to fall, right? Because we may be of a certain privilege and we just don't see it. Very normal, part of the human experience. That's why diversity is an asset, right? Diversity is an asset. And so, yeah, the eugenics movement not long ago, we still see vestiges of it today. And we just need to be very mindful and intentional of undoing that damage.
And I think someone else that we should definitely mention here is Margaret Sanger, the mother of birth control, but she was also involved in the eugenics movement. Is that right? Yeah. And I think that also gets to the point as to why Black women are less likely to be on birth control, like pill forms of birth control. I mean, I would be if the proponent of birth control is also saying that our race shouldn't be reproducing as much, you know?
Yeah, absolutely. Absolutely. So what you're getting at is how deep this stuff is. And I think it's helping us, your listeners, understand that the distrust that people of color are likely to have when it comes to medicine and the institution of healthcare it's rational, first of all. It's justifiable. And what we have to do as institutions is do better. Again, critically audit ourselves, learn how to co-create with communities. You got all this education, you know what the people need, and you just do what the people need. We need to stop that. We need to unlearn that. And we need to recognize we don't have all the answers. And what we have to do is humble ourselves and partner with communities and co-create interventions. Or sometimes we just got to get out the way. And communities have to find their way. Perhaps we have some resources to help facilitate that. But sometimes we are the problem, right? The folks who are running organizations or the clinicians or the practitioners. And it's important just to recognize that we don't know all the answers, and we have to work in partnership to co-create innovative solutions that can best meet the needs of a community.
Yeah, and I think just raising awareness about this is super important. I don't want to get into a whole abortion debate here, but with Roe v. Wade, I don't think people realize how communities of color are way more impacted by those policies, right? Because of this history, because of these 400 years of history, people of color are less likely to be in forms of birth control. So therefore, they're more likely to need an abortion or want an abortion. And we often just dismiss that.
Yeah, I think that, and when you look at that whole topic, when I heard about it, when it occurred, I was like, Black women, Black and brown women are going to be disproportionately impacted. And I wouldn't say Black women of color are more likely to need an abortion or they're more likely to not have access to the resources and services that are needed when that situation presents itself, right? And so when you have states that are saying, hey, you got to go to another state if you're going to get this, that is a public health issue, right? It's a public health issue. And it's scary because, you don't want, well, I don't want to get too much into but we want what's best for women, right? What's best for women. And that's a very personal choice as far as I'm concerned. Again, I'm a male. I'm not going to even touch it, right? I'm not going to touch it. But what I can say is I want what's best for my sister or my mother, and I will always support them in whatever it is that they need. Yeah.
Yeah.
So.
And I mean, I think there are disparities. There are definitely disparities in access to abortion services. But as I said, even in terms of just getting birth control, there are birth control deserts, right? And that may make them more vulnerable to needing these services.
Yeah, you're absolutely right.
Yeah.
Great point.
And then let's talk about forced sterilization of Black women. This one really shocked me because in June 1973, like, you know how recent that is? A 12-year-old called Mary Alice Ralph and her sister, a 14-year-old Minnie Ralph, they both were sterilized by local health departments funded by the government in 1973. I mean, it's just shocking.
Thank you for raising this topic and enlightening your listeners.
And giving the names, because I think
years ago.
I think it's very important to put their names out there too.
Say their names. We have to say their names. Yeah, it speaks to why we have the distrust in the system. And it's going to take a while to gain that. We have a lot of work to do, but acknowledging it is key. And again, what I am focused on as dean at the school is making sure that our students who are going into health careers, whether it's human science, global health, healthcare management, policy, that they know these stories, that they know the history. Because through that knowledge, they're going to be so much more impactful in this world. And it just scares me because you know how books are being pulled and, the students can't read these books because they really speak the truth. That's very scary, withholding the truth about American history from young people. Because if we don't tell these stories, we will continue to see racial unrest. We will continue to see killings. We will continue to see the 3 different types of racism that you mentioned earlier.
Yeah.
Right? So we have to tell our stories and we have to enlighten young people. Through that knowledge, they will be more compassionate providers. They'll be able to think from a systems level and think about what needs to be done beyond the institution of medicine to advance health. They'll be much better able to connect with patient populations and communities because they're going into these spaces with humility. That's what's been missing from curriculum. And, I worked for health systems, hospitals, community health systems before coming to Georgetown. And I was going to write about, right after the Affordable Care Act was passed, I was going to write about what are the new and emerging competencies that are needed to really get this thing right. I'm tired of talking about racial differences in health outcomes. I'm tired of talking about racism, right? But what needs to be done for the sake of health? And one of those competencies was around our history. And starting off with just a review of the history. I wrote about D.C. and the history of the District of Columbia since 1790 and identified milestones in policy and practice that disproportionately harm Black residents in the District of Columbia to help providers understand why we see these racial differences by race and by place in our nation's capital.
Yeah. No, and we're definitely going to talk about DC itself.
Yeah.
I just want to make sure we get through the history of everything.
Yeah.
I'm going to go through these super quick. I don't mean to diminish their importance, but I just want to get to how we can actually tackle in the landscape of racism in healthcare right now. So I had here the Tuskegee syphilis study from 1932 to 1972, where 400 African-American males were just let to survive to live with untreated syphilis to just see what the natural progress of syphilis was, just because they were curious. It was a government-funded program to just see what the natural course of syphilis was. Mm-hmm. Yeah. I mean, I think that definitely has implications now, and it had implications with COVID and African Americans being not wanting the vaccine or doubting the vaccine.
Right.
Exactly.
Right.
Then we had the HeLa cells and Henrietta Lacks in 1951. I don't mean to diminish the importance of this event, because it did bring a lot of good to the understanding of cancer and cancer cells. But there were just so many issues in terms of informed consent and privacy that people are scared, Then we had the Indian Health and Services sterilizations in the 1970s. From 1970 to 1976, they sterilized between 25 and 50% of all Native American women.
Yeah.
The history. We can't erase this history.
We cannot erase this history. You have to tell the story. And again, through these stories, I believe there are clues to help us fix the system, right?
Yeah. Yeah. So let's go into the current landscape of racial inequalities in the US. Let's talk a little bit about COVID. COVID was very, very recent. People were super interested in COVID. Overall life expectancy dropped in the US, but if you look at different races, it was very different, because whites and Asians dropped by 2 years in their life expectancy, African Americans and Hispanics by about 4 years, and then Alaskan Natives and Native Americans by 6.6 years. There are vast differences there. Would love if you could talk a little bit about that. I know you wrote a paper on COVID and reconceptualizing race in healthcare.
Yeah.
So, yeah.
When I learned, and many of my colleagues who do this work, when we learned how COVID was transmitted, we immediately knew Black and brown people would be disproportionately burdened. Why is that? Going back to south of Main Street, north of Main Street, and seeing how these communities are vastly different, right? So just let's take D.C. as an example. When you have folks who live in large apartment complexes and you have a high density of folks within a certain space,
transmission
is going to skyrocket, right? And that's what we saw.
Yeah.
When we had employers that, what was the word we use? Essential employers, right? Essential professions or careers, or essential workers. These are workers who were more likely to be exposed to the virus just because of the nature of their work, but the employers were not providing them with the personal protective equipment that was necessary to keep them safe.
And are those workers usually disproportionately of color?
Yes, correct. So we're talking about, your Uber drivers, right? Or restaurant workers, or people who work for post offices, those positions where you're moving around and you have a lot of interaction with folks. Obviously, that's going to be a challenge for you when you have the wonderful Anthony Fauci saying, stay put, be still, quarantine, right? Well, some people have to work. You can't just quarantine. And if the employer is not providing them, and at that point, there's a lot we just didn't know, right? So that helps explain why we saw Black and brown communities being hit hardest by this. And of course, there was also, and I know this varies by community, but some communities, the vaccine was released faster in communities that were white than other communities. Again, that varies by community. I don't really want to think that's a blanket statement, but we did see those trends early in the disease manifestation.
Yeah. And we talked about other social determinants of health earlier, and how even if you account for social determinants of health, you still see many disparities in health outcomes. Mm-hmm. Did they ever account for other social determinants of health when looking at COVID and maybe years of life lost due to COVID?
What do you mean?
So let's say, did they ever look at years of life lost in Blacks and whites while accounting for level of education?
Yeah, actually, I think we have some researchers here at the School of Health that looked at that. I think Professor Kramer, if I'm not mistaken, looked at all-cause mortality, comparing that to COVID mortality to kind of tease out those differences. That work has been done. I don't have the data off the top, but yes, it has been done.
Sure. Yeah. Because I think that would be something pretty interesting to look at too. Yeah. Now let's talk about DC.
Yeah.
You've done a ton of work in DC.
Born here.
Yeah, exactly. You've been here basically your whole life. Is that right?
Well, I left for school and came back, but yeah.
Yeah. But there's a lot in DC, very rich history, but also very racial history. There are a lot of topics related to race in the history of DC that I think are important for us to talk about here. So the community health needs assessment that we're working a lot on DC. I've seen a lot of differences between wards, east and west of the Anacostia River. We'd love if you could just talk about the landscape of differences in health outcomes in DC by race.
Yeah, it's pretty. Well, first of all, the interesting thing is DC, if you look at us as a city, we're a healthy city. We are a very healthy city, one of the healthiest cities in the country. So how about that for a soundbite?
Yeah,
right.
Brought to us.
But when we stratify health outcomes by race and ethnicity, there's a very dark story to be told, right? Diabetes, for example, in the data we released about 2 years ago, Black residents were 6 times more likely to develop and die from a diabetes-related complication than their white counterparts. You can take all the cancers, prostate, colon, breast. Black folks are more likely to die from those cancers in the District of Columbia.
So I was reading your paper titled Race, Place, and Structural Racism, a review of health and history in Washington, D.C. And there were 2 facts there that absolutely shocked me. I remember I was on the train coming back from Thanksgiving for the podcast, and I just jolted back on my seat. I even showed the person that was sitting next to me because I was just shocked. But you say that Black men and women in D.C. can expect to live 17 and 12 years less than their white counterparts. 17 and 12. So that means that if you have white males on average living to 80 years old, Blacks can expect to live to 63. That's crazy.
It really is. It's unacceptable.
Yeah.
It's unacceptable. And again, I can't say this enough. It's not race. It's racism, systemic racism. It's a difference in access to opportunity and resources. You can look at those same data and look at them by geography, and you can see that a lot of the harm and the pain and damage is east of the river, where you have 92% of residents are Black, right? In Ward 7 and Ward 8. Grocery stores, I don't know if you saw that statistic, but if you look at Ward 7 and Ward 8, those 2 wards combined make up about 160,000 residents. Okay, 160,000 residents. When we did our study, there were only 3 full-service grocery stores to accommodate 160,000 residents. A full-service grocery store is like a Safeway or a Giant or a Whole Foods, right? So you probably want context. Is that good? Is that bad? I don't know. Does that make sense? Well, Ward 3, with 80,000 residents, half of Ward 7 and Ward 8, at that time had 16 full-service grocery stores. 16. That's a disparity.
What are the demographics?
Very good.
Yeah.
Predominantly white in Ward 3, Ward 7 and Ward 8, predominantly Black. And then we wonder why obesity is higher east of the river. Some folks think that people don't have, there's food there. It's just not, it's not the food that's going to give us the best outcomes with our health, right?
Yeah.
So the food is there. Don't get me wrong. There's corner stores, there's McDonald's and Popeyes, and there's all these fast food restaurants there. But when we're talking about full service grocery stores, there's only 3, right? And so that is just one example that helps us understand that stark statistic that you just mentioned. The other is a lack of, and it's getting better now. We have Cedar Hill Medical Center coming east of the river, new hospital. Lots of new health services are coming now east of the river. I'm really excited about that. But for so long, it was a desert when it came to healthcare. And we also saw a lot of infant mortality, maternal mortality happening east of the river just because medical providers weren't there.
Yeah.
And that's bad. And you can Google it. The Washington Post has done some great work capturing these stories of these women who just could not get to a provider in time and either lost a baby or they lost their own lives.
Yeah. Something else that you mentioned in the paper. This one was even more shocking for me. You say, verbatim, the typical white household in Washington, D.C. had a net worth that was 81 times greater than that of the typical black household.
Yeah.
81. Is that true?
That's true.
Oh my.
That's true.
Okay,
that's true.
Yeah, that's insane.
I mean, you can look at the property values, right? You look at the property values in Ward 3, Ward 2 versus, it's different. It's very, very different. There are lots of other proxies that we can use, but yeah, it's a significant difference there. And again, begs the question, how do you explain that? Right? How do you explain that? Like, I have a house I've had this house for 15 years. And it's not in D.C. It's right on the outskirts of D.C. in Prince George's County. And I had another house in D.C., right? The house in Prince George's County, the property value of that house has not changed much at all in 15 years. And that house is in a predominantly black neighborhood that has not had a lot of change in 15 years.
Yeah.
Right? The house in D.C., the property value has, skyrocketed. So that helps explain, because we know that home ownership is one of the best ways to build wealth and have generational wealth. And so when you have families that either can't afford homes, or the homes that they live in are in communities where we're not seeing significant growth in property values or investment, people can't build wealth, right, in those types of environments.
Yeah. And getting to your question as to how did we get here with all these disparities that we see in DC, I think the history of DC is very important to understand.
Yeah.
I know you've done a lot with the history of DC. Could you?
Yeah. So,
that?
DC used to be, it was colloquially referred to as Chocolate City, right? In the 1970s, it's predominantly a black city. And we know that taxation without representation, because we are not represented, right? That has an impact on our health and well-being. And we typically see this showing up in the event of a public health emergency. COVID was a perfect example, right? When the CARES funding was released, DC got less money than two other states. I always forget who they are, but two other states that have a higher population. But we didn't get an equivalent amount of funding because we were not a state. We saw the same thing during the AIDS crisis, HIV, and the needle exchange programs. We knew that needle exchange programs were effective in preventing the spread of HIV during that time, and still today, right? And so the city wanted to fund needle exchange programs, but Congress wouldn't approve. And so it was redlined out of our budget. And so the city had to depend on the generosity of philanthropy to do needle exchange work in the city. Black and brown people were disproportionately impacted by both COVID and the needle, HIV, AIDS. Even today, Black and brown people are disproportionately represented.
Yeah.
So that's part of the history. And then, now we're seeing, because of property values increasing and the city's changed so very much over the past few decades, people are leaving. People who have Black residents who had homes that were paid for years ago can't afford to stay in the city because everything is just changing so rapidly. And they're also having a loss of community and cohesion because the churches are gone that used to be here in the city that brought people together. People are having to make a very difficult choice. The community health needs assessment, they would tell us this in many of our input sessions. I have to make a decision. Can I continue to stay here and make this work, or do I leave? Do I take the money? An investor is offering me $1 million for my home. My home is paid for. Do I take the money and leave? And we hear that way too frequently.
Yeah. This sparked two things that I've heard in the past couple of weeks. So one of them was the idea of proximity to Black. And I think it was in a podcast I heard that proximity to Black in itself can be a determinant of health. Whereas if your spouse is of color, the treatment that you get might be different from a couple that is just two white people. Is that true? That's
unfortunate, but yeah, I can see that. I'm not saying it happens all the time, but I can see, because of, again, white being perceived historically as the gold standard, right? And I'll say this with my best friend is a white male in North Carolina. And we always joke about these things. So now I'm going to put on my Christopher hat, not the Dr. King hat. But sometimes we're like, you know how the cops are profiling folks who are driving by race, right? And so my white friend has this joke. He's like, well, when you come down, let's just be sure that we're in the car together. That way you're less likely to be profiled, right? I mean, that's a perfect example of what you're talking about. Yeah. We would joke about things like, or I would say, I need you to come with me because I'm driving into this area at night. I need you to just be in the car with me because of what you're saying. Yeah, proximity to Black. Interesting.
Yeah, I had never really thought of it, but when they said it, I could totally see it.
It's unfortunate, right? Yeah. It's unfortunate. It's, again, that goes back to the stress. Just think about, I'm making fun of it, but think about how sad that is, that I am concerned about driving at night in North Carolina. And I'm not picking on North Carolina. So if you're listening from North Carolina, I'm not saying the state is, I'm just saying I'm in a community that has a history of profiling folks and treating them differently when they're pulled over because of race. That's something I have to think of, right? And we call that like the Black tax, right? It's like another layer of effort, or, we're thinking about something that folks don't even, my white peers don't even think about because of privilege, right? That's considered the Black tax. And we know that is a stressor, and that has an impact on our hearts. Literally, our hearts. Mm-hmm. It has an impact on hormonal distribution, and it's not good for us. Yeah. Which, again, helps us understand why we see hypertension rates higher in some populations over others, right? Yeah. Yeah. Another statistics that I heard these past few weeks was that in 2016, Harvard and Johns Hopkins did a study, and they looked at the top causes of mortality. And this is often not talked about, which I think is weird. But number 1 was heart disease. Number 2 was cancer. And number 3 was actually medical errors. They didn't talk about racial distribution within medical errors, but based on the system and everything that we talked about, I can only assume that there are going to be vast differences there too. Oh, absolutely. Oh, my goodness. Yes, we see this a lot, especially with persons who don't speak English as a primary language. You can see how that can really lead to a disaster. Communication errors are one of the most common types of medical errors we see, right? It's just miscommunication or not communicating, or making a biased decision because of, again, how the world has planted certain perceptions and thoughts about people just based on their demographic affiliation. Those things can lead to medical errors, and it's very scary. They happen way too frequently in this country. Yeah. And the idea about language is very interesting. It's a big barrier. I was shadowing a doctor in D.C., and D.C. has a big population that only speaks Spanish. And these patients would come in, and the treatment they received, although the physician would still give them the best care that he couldn't give as good of care to the people that also spoke English, just because his Spanish wasn't as well developed as his English was. I mean, he even had me jump in and try to understand some of the words that the patients were saying. And my Spanish is okay. I was doing my best, but still there has to be significant differences in health outcomes just because of things like this. Absolutely. Absolutely. Yeah. Yeah. Now let's talk about strategies to tackle all of this that we've talked about. How do we fix it, right? And I think something that you're a big proponent of is unlearning how we think about race, decontextualizing race into the deep-seated algorithms that exist. So would love if we could talk a little bit about that. Well, I am very excited about artificial intelligence. I'll say that first. We're going to talk about that at the end, because I'm very, very excited about that. I know folks are concerned about it, but I believe that as we think about opportunities to do better, I think AI can help us unearth inequitable treatment, inequitable outcomes in ways that we never thought of. Right? So I'm really excited about that. But it takes intentionality, right? And so we definitely need to build a skill set around vetting these algorithms, vetting digital technologies with an equity lens to be sure no population is left behind. And I think that's an opportunity for us as a school. So that's one. I know we'll talk about that later. The other is atonement.
That's a big one.
Atonement. And what is atonement? It's really owning up to the injustice.
And the history, too.
And the history, owning up to it, apologizing, and being very courageous in exploring ways to address it.
Yeah. And I see this a lot with my friends. They don't do it because they're bad people at all, but they think that they can fix racism by just completely ignoring race. Let's not think about it at all. But we can't do that when we have 400 years of history that tell us otherwise, you know? So we have to take an active approach to actually tackling all these differences.
Yeah, we have to. And folks who say, let's not talk about it, I am making an assumption here, but they're probably folks who are very privileged and they are not part of the community that's been historically marginalized and oppressed, and I'll choose the word. So it's easy for people to say that, you know. Many of my, over the years, white friends have said that. Aren't we exhausted? Let's stop talking about it. Well, if you are a Black or brown person, you're dealing with it every day in some way, shape, or form. So I'm hoping that you challenge those, your friends or those that you engage, to recognize that if it's not addressed, we will all be impacted in some way, shape, or form. And it's important for us to stand up when we go home for Thanksgiving or Christmas and we have family members that say things that really don't help the narrative in the direction we're trying to go in. We stand up and we challenge that mindset. And that is a very uncomfortable place for many people to be in. But who said that transformation is easy? It's not easy work. It's a heavy lift. I think the other thing that we need to do is do a better job in crafting language that unifies us and stops polarizing us. I think.
What do you mean by that?
When I'm talking to groups about race and racism, to me, it's important that everyone in the room understands why that topic is in their best interest, and not to ever finger point and say, oh, you're a bad person, but instead help people see the big picture. And through telling the story of our history, folks can begin to think very differently around different types of treatment that people have just because of race, right? You're much more empowered in how you process information.
Yeah.
And so what I am trying to do, and when I say we need to have language that brings us all together, it's focusing on the ecosystem in which we live, learn, the structures and that govern our society, right? And helping people make the connection between, well, if this community is harmed, I will be harmed. And the reason this community is harmed is because of this that happened in this decade or this decade or this decade. So I think that's work that needs to be done. And that's work that needs to be done across all communities. I talk to my Black peers that sometimes they're very passionate, can be very passionate about these topics. And I'm critical sometimes of them, and they're critical sometimes of me, because I'm like, hey, wait a minute, you're going to lose people if you go in with such a radical tone, right? Soften up the tone, bring people together, right? So I guess I'm like the Martin Luther King of this work and not the Malcolm X of this work, right? It's like, so, and then you also still need different approaches to do things, but that's the approach that works for me, right? It's how do we bring everyone together for the sake of health?
And what I think is important about any approach here is that we have to tackle the individual, the community, and also organizations, right? Because all of these are going to play a role in racism and fixing.
Yeah, and policy.
Exactly.
And policy.
The government.
Yeah. Right. Yeah. So there's a new, in Prince George's County, there's a new, oh my goodness. Anyway, there's funding that's now available for foster children who are in the foster care system after the age of 18. They get a check, right? They get a check, and that check is aimed to help them with expenses that are necessary. So it's not like this has to be spent on education. It's a check that can be used to help them make really wise choices around how they move forward, right? There's also in the district, for some babies or children that are at a certain level, there's funding that's being put aside for them so that when they reach the age of 18,
that's interesting.
Then those dollars can be used for, again, whatever. It's not prescriptive. These are dollars it's baby bonds. So really, really good. These are examples of policies that can, again, help us undo the damage and reflect atonement.
Yeah.
Right.
Yeah. So you were on the board of the Consumer Health Foundation.
Yes.
And I think that the whole organization as a whole embodies what you guys really preach when it comes to tackling racism at the organizational level, at the community level. So I want to touch upon a few points that I think are important when tackling racism in healthcare. And with that, I think it would be useful if you could use examples from the Consumer Health Foundation as to how you guys did that there. And I think the first one is we need ways to measure systemic racism in institutions or within our own organization. Could you just talk a little bit about that? Because I think that's an important starting point.
Yeah, I think that's a really great point. So I remember talking to some students about race being a social construct, right? And so we should not follow an algorithm that says after you determine that this person is a Black person, this is what you do, right? We have to be very careful about that, right? So the student said, I don't understand. Why do we collect data about race and ethnicity? Why do we even need to ask the question? Let's just do away with it. I think it'll be better for us all. I love that comment, by the way. I would love to be in a world where we can do away with the checking the box. But Gustavo, you know why we have to check the box? Because systemic racism is real. The pulse continues to vibrate. And when we collect data about race, ethnicity, language, right, or location, that helps us understand where the problems are. Mm-hmm. And that helps us to design culturally and linguistically appropriate interventions. That's why we need to continue to collect data about race and ethnicity. On the other hand, we have to do a better job helping patients understand why we are asking the question. Because you know why, right? We know people they're reticent to answer that question because they think they're going to have a very different experience. So you can see both sides of that, right? We need that information, but we also need to do a better job articulating to communities why that information is important and providing assurances to them so they know that they're not going to have a different experience just because they've checked the box. But unfortunately, they may have a different experience just because they check the box. So you can see it can be very, very complicated, but I think we understand why it's important and the work that we need to do internally to make sure folks are okay checking the box and that, in fact, they will not have a different experience based on checking the box.
Yeah. So let's go into the experience, right? I think something that's super important, as you mentioned earlier, workplace diversity. You mentioned that the hospital CEO that wanted to celebrate the
Margaret Betsy and Lucy's contribution to advancing medicine.
Exactly, right? Exactly. I think workplace diversity was what helped that idea flourish into something better.
Right.
Good intentions, but through workplace diversity, they made that better. So workplace diversity is something that's very important. We see that increasing throughout the US with DEI measures, but I know we've given examples, but what's the importance of workplace diversity?
Many. One is it is going to help patients feel better about the environment in which they're receiving care. If I go into an environment and I see folks who look like me, I see some similarity of myself in some of the providers, I'm just going to psychologically feel safer. That's one. Two, we know that diversity is key to innovation. You have different perspectives coming together to solve a problem. When you have these different perspectives, you're most likely to have a solution that is viable and sustainable and impactful, right? Three, through diversity, we're able to capture our biases better than if we're with the same population.
Such as the example that you gave us.
Yes. We're able to catch we catch ourselves before we fall, right? Because someone else has looked at our work. I say, wait a minute, what are you doing? You cannot let that out. You know how many companies have been sued or they've just lost business because they put something out that was just like so wrong.
Yeah.
Like, who in your marketing team approved this? Did you not have some diversity on your marketing team, right? So there's a business case for diversity. There's a business case because you're able to develop a product or service that reflects the needs of different populations. That's why it's important.
Yeah. Yeah. And I think a couple more important things here. I know we're running short on time a little bit, but our policy interventions, education, we have to change the way that our education system works and address these things. Because if we don't address them, then we're going to retain those biases, right? Even though medical schools are not teaching students that African Americans have thicker skin, well, these are ingrained biases that we have to address. We have to say that they don't have thicker skin. Right. And we're not, in many institutions, we're not doing that right now. Right.
You're absolutely right. You're absolutely right.
Yeah.
And again, we just need to, I thought that study was just such a powerful study. And all medical students, I think, needed to read that for educational purposes, right? Not only medical students, but current providers, right? Because they're the ones who are still practicing. And through our community health needs assessments, the community tells us they have these types of experiences in medical institutions.
Yeah.
But yeah, here we are, the medical providers. You got to come every year for your preventive check exams, and we're doing our best to keep people healthy. And we question why we're not seeing populations or why we're not seeing significant improvements in health outcomes, or folks are disengaged or disconnected from the institution. There's a reason for that, right? So through diversity, I think that's one of the solutions to address that gap.
Yeah.
But yeah, it's a lot of work that we have before us.
Yeah. And then just raising awareness is also a big part of this. I mean, through things like this even, educating other people, letting them know that they should speak up. They should be active about racism in their communities.
Yeah.
So that's great. That's great. Now I want to talk about philanthropy.
Yeah.
I think philanthropy is very interesting, and it's hard to distinguish between pure and good intentions in philanthropy and just kind of following along with what the capitalist system is exposing onto us. I know all companies now have DEI measures. They're hiring more people of color because of the many aspects that you brought up. Right. But I get the sense that many of them are doing that now just to fit in because that's what seems right to do. Right, because other companies are doing it. Oh, we want to be in the same spot of them as them because of this capitalist society. Do you ever get that sense? And do you think it is bad if that's happening, or do you think the net positive is still better because these policies are still in place?
That's a great question. I think it's bad. I'll give you an example. Again, after the murder of George Floyd, I had CEOs and presidents of philanthropic organizations ask me to review their anti-racism statement that they're going to put on their website. And the majority of the ones that I read were very well crafted, but they also were missing something. They were missing what they're going to do about it. So they had a really nice great philosophical verbiage around being against it and condemning it. But I would push back and say, what are you going to do about it? How are you going to invest in this? If you're a philanthropic organization, how are you going to invest differently to tackle these root causes of racial differences in health outcomes? And what are those metrics going to be? If you're not ready to do that, don't put the statement out, because the community's watching, and the community is very, very savvy, and the community is tired of exploitation, right? And so I would push back. And if you have metrics, you need to be transparent. And those metrics performance needs to be released to the public. How are you doing against these metrics? What are you doing? How are you investing differently? That's what needs to be done. But if you just have a company putting out a statement and nothing, that's not good. I think that does more damage.
You think so? Okay.
I do.
Okay. Now I just want to touch on a roadblock that I think people will run into when trying to address race, and that's the idea of narcissism in our society. I know philosophers have been talking about the growing sense of narcissism since the early 1900s, where people focus on themselves and they want what's better for themselves. And as you said, that's kind of the mentality in the US, right? We want the US to be good, and other communities, other nations doesn't really matter, right? It's all about national security. It's all about individual rights. So I think this idea is interesting because it might present itself as a roadblock when trying to tackle a lot of this. So I would love to hear a little bit more about that.
No, I agree. I think that our founding values, not all of them, really are an obstacle for us because we're so focused on individual rights and a nationalism approach to how we think about our place in the world. Instead, what's best for the community in which I live, learn, eat, and play, right? What's best for the world in which I live is the approach that I think we need to have if we're going to do better for humanity.
Yeah.
Right?
And I mean, I think that's important for us to be aware because I think it's become normalized to be focused on yourself here in the US. And we can't just let that go by like that.
No, we can't. We really, really can't. And social media is also having a detrimental impact on our existence. It scares me. It's something that, as we think about increased incidents of crime, criminal behavior, we've seen this increase that can be traced back to social media. And we really need to get on top of this. I don't know what the answer is. I think that's work that we can pursue as a school. But social media has really gotten out of control and people are becoming more isolated as a result.
I just think we need to learn how to harness the power of social media to do positive things because there's a lot that can be done to improve, to raise awareness, but we just need to use it in the right way. And I think that that's missing.
Yeah, I agree with you. Just the same as AI, right? It's like, these are innovations, wonderful breakthroughs. Think about the fact that I can have a conversation with someone in a different country and we can collaborate together. I love that. There's wonderful things that can come out of our digital world that we live in now.
But we can use it to make things worse,
make
things better.
Right. How do we use the gift of technology for good and not do harm?
Yeah. How would you say we should go about that?
Oh, that's a tough question. Yeah. Oh, goodness gracious. I think that we have to think, I look at different countries and how they're dealing with social media, and some have more restrictive policies, particularly when it comes to children. I think that's a conversation we need to have as a country, right? What types of restrictions might we want to impose on certain populations because it's harmful, because they may not be mature enough to be exposed to. I'm not saying that's the answer, but I think it's worth a conversation, right? Because some countries are much more strict when it comes to social media and what that looks like and what's available to people. And here this is the United States, freedom of speech, yay, right? So I think freedom of speech is wonderful, but when people's lives are harmed and we see hate speech, that's a problem.
Yeah, no, definitely. Yeah. I mean, that all makes a lot of sense. Now let's talk about AI. You mentioned AI earlier, but people are super excited about AI. And I think there are a lot of ways that we can use AI to help. There's some ways that we can use it to hurt. But where do you see AI in the future of healthcare, especially when it comes to addressing racism?
Yeah. Again, I think AI certainly has a role. And it can be very strategic in our effort to eradicate racial differences in health and healthcare, to better pinpoint where racism shows up in a person's lived experience. I think AI can help us with that. My concern, and of course, not to mention the clinical work that can be done where you can use AI to maybe predict a person developing a specific type of cancer, or we're seeing this already in medicine, which is really, really exciting. But what we have to do is just get in front of it, right? We have to get in front of it and make sure that it's not causing harm. And the technology is happening so fast that policy and regulatory guidelines are behind. And that scares me. right? Because people are taking this and running with it. And again, they could be doing harm, right? They could be doing harm. So we just need to be sure that we're on top of it.
Yeah, no, I think that's great. And I think that even in a clinical setting, we can maybe use AI to eliminate some of the biases that we're seeing from providers, right? I don't know if that could be implemented, but maybe AI can come in and the AI won't have the same biases that physicians have.
Right. Absolutely. Absolutely.
Yeah.
But we have to know the right questions to ask AI. I went to a wonderful training on AI, and it was like, there's a lot that we can glean from it and learn from it, but we also have to ask AI the right questions. We have to be very, very specific with the language that we're using when we ask specific questions. And if we know the right questions, we're likely to get an output that is realistic and can really give us the right information.
Yeah.
So,
this was all great. Dr. King, thank you so much. I learned a lot, and I'm glad we're helping raise awareness about this.
No, I want to thank you for your work, Gustavo. This is an important topic. To the listeners, I hope that you found this very informative, and I'm hoping that it has inspired you to, again, use your life so that the world is better off than it was when you arrived, right? And that's my life's motto. It's like, how do I make sure that the world is better off when I arrived? And so this conversation tells the story. So thank you. Thank you.
Yeah. Thank you very much.
All right. Thank you.
Thank you for tuning in to this episode of the Gustavo Franco podcast. We hope our exploration of the world of healthcare has been insightful and thought-provoking for you. Remember, the opinions expressed here are ours and of our guests and should not be considered professional advice. This podcast is a collaborative learning experience for both the producers and listeners. While we strive to convey accurate and up-to-date information, we acknowledge that our research may have limitations. We encourage all of our listeners to supplement their knowledge by conducting their own research. If you enjoyed this episode and want to stay up to date on our future releases, make sure to subscribe or follow us on your preferred podcast platform and social media. We highly value your feedback, so please don't hesitate to reach out with your thoughts, questions, or suggestions for future topics. Thank you for joining us on this healthcare exploration. Together, we can foster a more educated America and contribute to a more effective healthcare future. Until next time, take care and stay informed.